For those of you who don't know me, my name is Nancy Marks Erickson. I lead the Women with IBM group with a tremendous amount of help. Today, we have several people um, who are working with us that help make this Swallow Symposium come to fruition. Uh, Today's program is the physician's approaches to dysphagia, what physicians can offer, their insights, their intervention, and support. As IBM patients, we all know that dysphagia is a major part of our journey. So we're excited to have two superior speakers talk to us about how we can make our life a little bit easier. There, so I guess we'll get going. The next slide, please. For those of you, the Women with IBM Group's mission is to improve the lives of women affected by inclusion body myositis through virtual connections and support that transcend geography. Next. How we do this. For over 5 years, our goals are to build and create a sense of community amongst women with IBM, to network and collaborate, to share ideas, to thrive with IBM, to obtain information from professionals in the field, to find joy and hope along our journey. How this happens. We offer a safe and welcoming environment with privacy for sharing, vulnerability without fear of judgment, and valuing the experiences of one another. Next, please. Before we get started, TMA does not give medical advice. Our educational webinars are informative, and we encourage you to make all your decisions of care in partnership with your healthcare team. We are grateful for our expert speakers from all over the world. And we ask each speaker to disclose any potential conflicts at the start of their presentation. So for all of you who are here today, we ask you to please remain muted. All of the questions that we received have been submitted to the presenters in advance. So we're excited that all of this is going to be covered. Thank you. Next, please. Next. Are we okay? Sharon?
I'm so sorry,
Good.
Nancy. For some reason, the button's not advancing. I'm trying
Okay.
several different ways.
Do you want me to take it from here, Sharon?
You would have to, pull yours up to share
Okay,
it.
it's up. It's up. So we're just going to
But is
change.
it? I don't know. There it goes. It just went. I don't
Okay.
know why it froze.
Okay.
Okay.
We're good.
Sorry.
Okay. For our agenda today, and I just want to go back several months. Uh, as we know, dysphagia is a major part of our day-to-day lives. We started talking about this possibly a year ago. I know it was a problem for me, and I was talking to Rhonda, and before we knew it, we said, let's have a swallow symposium. So, with the help of Rhonda and Sharon and Laura and now Muriel and everyone, we are excited to be able to share what we've learned and offer all of this expert information to those affected by IBM and their families and caregivers. So as you see, we have our welcome what physicians can offer. We're really excited to have two stellar presenters, Dr. James H. Clark, who is the co-director, of the Johns Hopkins Dysphagia and Deletion Clinic in Baltimore, and Dr. Mike Yang. Mike is the clinical assistant professor of laryngology at UT Southwestern. Their presentation will include complement what both Teresa and Janine talked about in April. They're talking about various treatment options, interventions, research, pros and cons of treatments. And they will also talk about communication with them and how we communicate our dysphagia problems with the other doctors that are part of our care team. Then we have some personal stories that will come from Donna, Janet, and Sharon. Then we look ahead to the future. So with that, we'll see if we can go to the next slide. And I will introduce our two speakers. Okay. Sharon, I guess we're having a problem again, huh? So here we go. Dr. Clark. Dr. Clark, as I said, is the co-director of the Dysphagia and Deletion, I can't pronounce it, clinic at Johns Hopkins. He is an assistant professor of otolaryngology, head and neck surgery. His training includes the Royal College of Surgeons in Ireland, where he graduated with honors, residency, head and neck surgery at Johns Hopkins, his fellowship, head and neck oncological and reconstructive surgery and medicine, and he is a board certified otolaryngology, head and neck surgery. And as we're here, his expertise is in swallowing disorders and anyhow, I'm sorry, I can't pronounce it. Reflux, chronic cough, Zenker's, diverticulum, esophageal motility disorders, minimally invasive office procedures. He has numerous awards, including the Henkel Chief Resident Teacher of the Year at Johns Hopkins. And Dr. Clark, as a lot of us know, is known for his clear communication, compassion, thorough evaluation, and highly rated for patient respect, clarity, and expertise. Dr. Yang, um, Dr. Mike Yang, is a clinical assistant professor, the Division of Laryngology, and the director of the University of Texas Health San Antonio Voice Center, the Brian and Seth Distinguished Chair for Voice and Airway Disorders. His training is at Washington University in St. Louis. his residency in otolaryngology at Louisiana State, and his fellowship with Dr. Gregory Posma, who is one of the top laryngologists in the U.S. at the Medical College of Georgia. Dr. Yang's expertise is in voice disorders, airway disorders, swallowing disorders, advanced laryngology evaluation and treatment. He has written and contributed numerous peer-reviewed publication, textbook chapters, and is a regular presenter at medical conferences. But both of these physicians are very, very involved with IBM and have treated numerous IBM patients. So let's give a grand welcome to both Dr. Yang and Dr. Clark. And with that, we will turn it over to either Dr. Clark or Dr. Yang. I'm not sure who's going to have control.
I I will start. So I'll pull up the presentation if that's okay.
Absolutely, it's all yours
Perfect.
from both of you.
And let me see now.
Thank you for those
Perfect.
introductions, Nancy. We're both very happy to be here and talk a little bit more about this.
Perfect. Are you able to see my slides?
Not yet.
Let me see.
I know we saw them earlier.
Yeah. Oop,
Here we go. Here we go.
screen
Okay. Whoops, that's Zoom.
Yeah, let me just change that. Sorry.
That's okay. We're all having technical problems today.
Perfect. I think I'm good now.
Okay. We're great. Yes.
Okay,
Thank you.
perfect.
Oh, and
Well,
by the way, to everyone, this will be recorded and put on the TMA YouTube website. So if we miss something, come back. We can listen to it a second time. Thanks.
well, let me start off by, echoing Mike's words. Thank you so much for having us and giving us the opportunity to talk today. And thank you, Nancy, and your team for putting everything together. So after that warm introduction, I feel a lot of pressure on my shoulders now to live up to expectations. As Nancy mentioned, I'm the co-director of the Johns Hopkins Department of Otolaryngology Dysphagia Clinic. And today, as you guys know, we're going to talk a little bit about swallowing difficulties associated with inclusion body myositis. We don't have any relevant disclosures, and we're not using any non-FDA approved uses today. By the end of this talk, my hope is that participants will have a basic understanding how normal swallowing works, recognize how inclusion body myositis can affect swallowing, appreciate how swallowing problems are evaluated, and learn more about treatment options that may help improve swallowing and reduce complications. So we'll start by talking about the complexity of swallowing. Although swallowing is a reflective action that most people perform more than 1,000 times each day with little conscious thought, a normal swallow is a remarkably complex action. It requires the precise coordination of 6 cranial nerves and more than 25 pairs of muscles across the oral cavity, pharynx, larynx, and esophagus to come together and work together. Swallowing is often described into 4 phases. The first phase is the oral preparatory phase, followed by the oral transit phase, and then the pharyngeal phase, and then the esophageal phase. Although we describe these separately, they function as one coordinated sequence. The goal is simple but remarkably complex: to move a food or liquid from the mouth to the stomach while protecting the airway. Ooh, I'm sorry. Back. Uh, the first phase is the oral preparatory phase. This is where food is chewed, mixed with saliva, and formed into a soft, manageable bolus. The tongue helps shape and hold the bolus against the palate, preparing it for transport. The second phase is the oral transit phase. This part remains under voluntary control. Once we're ready to swallow, the tongue presses against the hard palate and pushes the bolus backwards towards the throat. As the bolus reaches the oropharynx, the swallow reflex is triggered. The third phase is the pharyngeal phase. This phase is largely involuntary and happens very quickly. Once it begins, we can't really stop it. During this phase, the soft palate closes off the nose to prevent things from refluxing up into the nose, and protects the vocal cords and the vocal cords and the arytenoids, which is the back of the vocal cords, closed to protect the airway. And the epiglottis, which is a cartilaginous structure in front of our vocal cords, falls back to stop things from going down the wrong tube. At the same time, the hyoid bone and the larynx or the voice box move upwards and forwards, helping move the airway out of the path of the bolus and assisting with opening of the upper esophageal sphincter. The pharynx then contracts to guide the bolus into the esophagus. The fourth phase is the esophageal phase. Once the bolus enters the esophagus, coordinated esophageal contractions move it towards the stomach. Liquid may partly move by gravity when a person is upright, but solid foods generally require active peristalsis. The lower esophageal sphincter relaxes to allow the bolus to enter the stomach. In terms of timing, the pharyngeal phase is extremely fast. The bolus can travel up to 40 centimeters per second, and normal pharyngeal transit usually takes less than 1 second. Once the bolus enters the esophagus, however, the transit slows considerably to around 4 centimeters per second, with the time it takes to travel through the esophagus typically taking between 5 to 6 seconds, and we would usually consider it abnormal if it's above 15 seconds. What I find very strange is that there's no universally accepted definition of what dysphagia is. It's most commonly described as a patient-reported sensation of difficulty with swallowing. This may manifest as a perception of impaired bolus transit, obstruction, choking, or coughing during swallowing. Importantly, the severity of symptoms do not necessarily the severity of symptoms do not reliably correlate with the degree of physiological impairment. Some patients report significant dysphagia in the absence of any objective abnormalities, whereas others demonstrate marked dysfunction, such as silent aspiration, where food or drink goes down the wrong tube, despite them not noticing it. So the degree that patients describe as symptoms doesn't necessarily correlate with the severity of dysphagia. So next, we're going to talk a little bit more about inclusion body myositis. So as everyone probably knows, it's a sporadic inclusion body myositis, or IBM, is the most common acquired inflammatory muscle disease in people over the age of 50. Symptoms typically begin at around 60, and the condition is more common in men than women. IBM is a slowly progressive muscle disease. We don't really fully understand why it occurs, but several processes appear to contribute, including the immune system activity, abnormal protein buildup within muscle cells, changes in muscle energy production, and possible nerve-related degeneration. Over time, these processes lead to gradual weakening and wasting of specific muscle groups. And IBM commonly affects the thigh muscles, which makes it difficult to rise from chairs or climb stairs, and the finger flexors, which makes grip strength weaker. But importantly, IBM can also affect the muscles involved in swallowing, which is why dysphagia is such a common and important issue in this condition. It's reported that the prevalence of dysphagia among IBM patients ranges from 40 to 80% of people with a diagnosis. Now, I'd like to take a moment and just stop here, because if we look at this number, there's a huge discrepancy between 40 and 80%. And if you go through the literature, these are the numbers that are commonly quoted. And there's just such a big discrepancy. And one of the projects that we are actually involved in right now is trying to get a better understanding of the actual percentages of people involved in this. So we're about to start a study at Hopkins where we're going to be submitting a link to a database to try and collect some data from patients with IBM so that we can better understand what the actual number is, and also get a better understanding of how it's impacting your lives. So please look out for these links, and we really appreciate you taking any time to fill them in. But let me move on. So IBM can affect swallowing because, as we know, swallowing depends on multiple muscles working together with strength, timing, and coordination. In IBM, some of these muscles gradually become weaker and less efficient, and this can affect swallowing at several points. First, IBM can involve the tongue and oral phase of swallowing. As we know, the tongue is responsible for controlling food in the mouth, mixing it with saliva, forming it into a manageable bolus, and then pushing it backwards towards the throat. When the tongue is weak, food may become harder to control, and people may notice that food collects in the mouth or gets stuck between the teeth and the cheeks. Second, IBM can affect the pharyngeal muscles, which are the muscles of the throat. These muscles normally squeeze in a coordinated way to move food and liquid through the throat and towards the esophagus. When these muscles are weak, the bolus may not move through efficiently. Food or liquid can remain in the throat after swallowing, which may cause a sensation of sticking, repeated throat clearing, coughing, and the need to swallow several times if material spills towards the airway. It can also increase the risk of aspiration. It is all over the place. Sorry about that. Third, IBM is commonly associated with problems of the upper esophageal sphincter, or UES, which is the area where our throat and esophagus meet. The UES is a muscular valve at the top of the esophagus. It normally relaxes and opens briefly during swallowing, allowing food to pass from the throat into the esophagus. In IBM, the upper esophageal sphincter may not open fully, or it may not open at the right time, which creates a bottleneck, so food has difficulty leaving the throat. Even if the swallow is strong enough to move the bolus downwards, it may meet resistance at this point. So in simple terms, IBM can impair swallowing by weakening the tongue, reducing the squeeze strength of the throat, and creating resistance at the entrance of the esophagus. These problems often overlap, and the goal of the evaluation is to understand which part the swallow is affecting, so treatment can be tailored towards individuals. So this is just a neat video where it kind of shows some of the anatomy that we were talking. So I'm going to, so if we're looking here, this is the back of your voice box. This is the right vocal cord here, left vocal cord. and then the voice box gets pulled forward to open up the esophagus. And here we see the main component of the upper esophageal sphincter coming through. And this is a muscular band here called the cricopharyngeus muscle, which comes across here, which is often the culprit in inclusion body myositis. And here we can see this on a swallow study, where we can see this indentation or nearly a thumb mark, and that corresponds to that muscle that we saw, the cricopharyngeus muscle. And it's not uncommon to have some prominence of this muscle, but as this muscle becomes stronger or bigger or doesn't relax, we see that that thumb mark gets bigger and bigger. And here in this far right picture, we see a severe obstruction, and we can see how there is a backflow or a bottleneck of the contrast extending up the oropharynx. So let's talk about the long-term complications of this. So sarcopenia is the medical term for muscle loss, and dysphagia and sarcopenia are closely connected because both reflect loss of muscle strength and function. In IBM, this relationship is particularly important because, as we know, IBM can weaken the muscles of the tongue, pharynx, larynx, and upper esophagus, making swallowing less efficient and increasing the risk of residual food bolus, aspiration, and prolonged meal times. As swallowing becomes more difficult, however, patients may eat less, avoid protein-rich food because those are typically the foods that are challenging for us to eat, and consequently lose weight. This can worsen overall muscle loss and further reduce swallowing strength, creating a cycle in which IBM-related weakness, dysphagia, poor nutrition, and sarcopenia reinforce one another. The other thing that happens is when the cricopharyngeal does not relax or open properly, it acts as a tight doorway at the bottom of the throat. The pharyngeal muscles then work harder to push food through the narrow opening. Initially, this may simply cause a sensation of food sticking or the need for repeat swallowing. But over time, the constant resistance can make the swallow less efficient, and food may remain in the throat after swallowing. And the pharyngeal constrictors may become stretched, fatigued, and weakened. In patients who already have muscle disease such as IBM, this is especially important because the pharynx may not have enough reserve strength to overcome the obstruction. So, and again, we can see in this picture here, let me see if I can get my So here we see the little thumb mark of the cricopharyngeus muscle, and this is where the constrictors are. And what we have seen in this over time is that as the constrictors have tried to push the bolus past this narrowing, they've eventually started to balloon out and they've become a lot wider and are losing strength. Now, there's also an area of inherent weakness in the back of the pharynx here called a Killian's triangle. And over time, that can sometimes give out and you can get the development of what's known as a Zenker's diverticulum, which is a little pocket just above the muscle, which again, food can get trapped in and cause more problems with swallowing. And then the big fear with this is for aspiration, where because the bolus isn't coming down and passing into the esophagus, it's just sitting in the back of the throat. And if we get too much content there, it can overflow into the airway. And here we can see the airway right here, and we can see the contrast sneaking in, which would be what we would consider aspiration. And next to it, we can see a chest X-ray showing a pneumonia, which has resulted from aspiration. So obviously our goal is to avoid this situation. So finding help. So finding help for this can sometimes be challenging because a lot of the areas that we're talking about, particularly the upper esophageal sphincter, kind of falls between specialties where some GIs are happy with it versus, some ENTs are happy with it. So it's finding someone who is able to take care of it. And that's where having a multidisciplinary team comes in. As I can, talk for Mike and myself, we are probably not the doctors who you would want to come to get diagnosed with IBM or, to kind of address all the issues of IBM, but we can definitely help with swallowing. Same as, we would definitely want help from a nutritionist to make sure that you're getting the right caloric intakes and, maximizing energy. And same as, working with speech therapy to make sure that you're keeping as much strength in those muscles as possible. So having a multidisciplinary approach is vital here. So how do we evaluate swallowing function? So it starts off very simply with just talking and where we want to kind of understand how you're maintaining your nutrition, looking for signs of dehydration or weight loss. A lot of patients come to my office and I will ask them specifically, do you have a problem with swallowing? And they'll say, nope. And then I say, okay, tell me about what you eat. And then they'll say, well, I can't eat meat anymore because whenever I eat meat, it gets stuck. So I just don't eat that anymore. So what they've done is just adjusted their diet rather than recognize that they have a swallowing disorder. And then it's important to ask about other things like how long does it take you to eat your food? Because a lot of people with swallowing problems, even though they may not recognize it as a swallow problem, will say, well, it takes me about an hour to eat, and I'm always the last one at the table. So it's important to look at these multi factors when evaluating the swallow. And then you also want to ask about things like pneumonias because we want to know about aspiration. And also the social impact of this, the number of patients that come to my clinic and, won't go out to restaurants anymore because it's just too stressful to be out and about and eating. So these are all things that we would be looking for when talking in clinic. The next kind of what it's very commonly performed in my clinic is what's known as a fiber optic laryngoscopy. What that means is that we would numb up your nasal cavity and we put a little camera up through your nose. We look at the back of your nose to see how your soft palate is coming to make sure that it's closing properly. And then we would go down further and get a view of your voice box. And here on this image, we can see it. So we're looking down. The back of the tongue is kind of off screen in this area here. And here we see the epiglottis. That's the structure. It falls back to stop food from going down the wrong tube. This is the wrong tube. This is the opening to the trachea or windpipe. This is the left vocal fold and right vocal fold. And here's the back of the voice box. And then down here, it's closed right now as it should be, but that's where the esophagus opens to take the food from the throat down to this esophagus. Now, if I saw this in clinic, I would be very suspicious for a swallowing issue because we see an accumulation of saliva here in the back here in the area we call the piriform, which tells me that things aren't going down as efficiently as they should. One of the questions that we got was, about wet voice and what that means. This is probably what you're asking about, where the saliva is just sitting here. So when you're talking, some of the saliva is slopping over, and it kind of is giving that bubbly sound, and you can hear the saliva interacting with the wind of talking, or the airflow of talking. The other thing that we will commonly do is what's known as a flexible endoscopic evaluation of swallowing, or FEES. Again, this involves performing a flexible laryngoscopy, and we give patients various food substances that have food dye in them so that we can see them better. And it allows us to assess how the body, or how the throat and muscles are pushing the bolus down. So if we look at this study here, we can see that there is yellow contrast below the vocal cords, which shows that this patient is aspirating, and it's probably not safe to have a regular diet. Next is the video fluoroscopy, which is probably the gold standard when it comes to evaluating swallowing. So video fluoroscopy is performed with a speech-language pathologist and is the cornerstone of dysphagia evaluation. It uses barium of various consistencies, and typically we'll also use a 16 millimeter barium tablet to assess swallowing across all phases, and it provides both anatomical and functional insights. Video fluoroscopy also helps identify distal causes of swallowing issues, such as the esophagus, which obviously the FEES is unable to do because we're just staying in the upper part of the throat. I'll touch very briefly on high-resolution manometry. High-resolution manometry is a test that measures how well the esophagus is working. A thin pressure sensing tube is passed through the nose and into the esophagus. As the person swallows, the test shows how strong and how smoothly the esophagus moves food downwards, and how well the valves at the top and bottom of the esophagus open and close. It's considered the most accurate test for diagnosing problems with esophageal movement and coordination. And then next, we'll touch briefly on transnasal esophagoscopy, or TNE, which is something I perform, and I'm sure Mike also does it, which is a well-tolerated office-based procedure that allows direct visualization of the esophagus in an awake, upright patient. Essentially, what we do is we have a very similar scope, although much longer, to the one that we use for flexible laryngoscopy, and we pass the scope up through the nose, down through the throat, and down into the esophagus, and down to the stomach. It allows us to identify any structural pathologies, rule out concerning lesions, and, as said, guide management. I can also do biopsies through it. And the real beauty of this is that we can avoid doing procedures under sedation because patients can tolerate it awake in clinic. So I'm going to hand over to Mike now to talk more about management options. And Mike, I can advance slides if you want.
Okay, perfect. Thank you. Yeah, James, that was great. That was a great summary of kind of the options that we have for working up swallowing issues, and also the function of the swallowing tract and symptoms. And to kind of piggyback on some of the points that you were making, a lot of the questions that we got were about when should people seek care, when should patients seek evaluation. And so, to focus on one of the points that you made, having subtle symptoms, I think, are really important, right? And I think that's something where people can convince themselves that maybe problems aren't as serious as they are. But the nature of inclusion body myositis and swallowing disorders is that over time, symptoms tend to get worse. And so, my advice in general usually is for as soon as you have a diagnosis of inclusion body myositis, or even when you start noticing subtle symptoms, to talk to the quarterback of your team, which is typically your neurologist, and ask about different centers that could potentially help with the swallowing symptoms. Some of those subtle symptoms include things like needing to take smaller bites, chasing with liquids, modifying your diet, like Dr. Clark had mentioned. And then just the nature of the multidisciplinary clinics in our center, all of our patients, when they see me or my partner for the first time, we have speech language pathology partners, and we will evaluate patients together and come up with a treatment plan together. And that really helps us guide multidisciplinary decision making for best treatment options that are available. And so, if you don't mind advancing the slide, James, one of the cornerstones of that is working with speech language pathologists. Laryngologists, which are what James and I both are we're surgeons who treat voice, airway, and swallowing disorders, and we're a subspecialty of ENT or otolaryngology. And so speech language pathology is kind of the sister field to laryngology, where they also treat voice, airway, and swallowing problems, but typically in a non-procedural way, where pertaining to swallowing disorders, they kind of fall into three main categories of recommendations for patients. So those include swallowing exercises, right? Basically things that you can do to try to recapture strength or maintain strength and coordination of your swallowing. Compensation. So what that means is if there are issues with the swallow mechanism that are difficult to address, what can you do to try to compensate for those problems? And then things like pacing and textures. So what Dr. Clark showed in that earlier swallow study was aspiration. And so sometimes certain consistencies are more likely to be aspirated depending on people's individual swallowing mechanisms. And so sometimes speech language pathologists can provide recommendations about specific textures that are safe, maybe some that are less safe, and how you can modify those textures while still maintaining nutrition. As far as what Dr. Clark and I focus on primarily when it comes to treatment options, those are more the procedural options that we'll go over next. And so if you could go to the next slide, please. So the procedures that we have for patients with included body myositis typically revolve around the cricopharyngeus muscle. Okay, so that's just the name of the muscle. And that's the main muscle that separates your throat from your esophagus and kind of is the gatekeeper for entry into the esophagus. All right. And so when we're thinking about transitioning of what we're trying to swallow, of what we're trying to move from the mouth to the stomach, the muscles in the throat really work as a pump to help push food down into the esophagus and keep them out of the airway. The cricopharyngeus muscle, which is a part of the UES or the upper esophageal sphincter, was mentioned earlier, essentially is a valve that stays closed at rest and opens when we swallow to allow food to pass. Okay, so it stays closed for a few reasons. One, we don't want things coming back up, right? So if we have things sitting in our stomach or esophagus, that's kind of the barrier, the last line of defense to keep things down instead of coming back into our mouth. And it's also a way to keep us from just constantly swallowing air. All right. And so the treatment options that we have pertaining to IBM, when we target the cricopharyngeus muscle, kind of fall into three basic ideas. One is a dilation, where we stretch that muscle open. Two is Botox, where essentially Botox is a medication that weakens muscles. So it's a liquid, and once you inject that liquid into a muscle, it weakens whatever muscle you inject it into. And the idea is that because the muscle is closed at rest, if you weaken it, then in theory, things would be able to go down easier. And then a myotomy, which is when we physically cut that muscle or remove a piece of that muscle, right? That muscle works as a valve, almost like a ring. And so if you cut it or you remove a segment of it, then that ring is no longer in continuity. And essentially it is more relaxed or open, all right? I think a key point to treatment options especially when we're talking about inclusion body myositis, is that there is no consensus among providers about what the right treatment options are for patients. And so we'll just kind of briefly touch on these and the data that are published out there on these options. And I can certainly give my opinions as well. Okay. So the first option, dilation. The picture on the left is showing a balloon. Okay, so dilations can be done with a balloon. This is looking straight down the barrel of that balloon. Okay, so the balloon is usually connected to a shaft, and once you fill it with saline or water, then that balloon will inflate. And as it inflates, it kind of expands radially like this to stretch open whatever you're trying to stretch. And what you're seeing on the right is essentially a patient who's having a dilation of the cricopharyngeus muscle of the UES, where that balloon's been inflated and it is stretching open that muscle. Okay. Dilations and Botox and really myotomy, really all three of these options when it comes to treating this muscle for inclusion body myositis patients, really understudied. If you look at what's been published for dilation for inclusion body myositis patients, there are two studies that come out of Europe that look at patients with a series of 13 patients, right? Those are the biggest ones. And there are a few case studies and very even smaller series. And they're kind of all over the place, right? So essentially, um, some say that dilations help. How long they help is kind of also all over the place. And then some say that maybe dilations may not help as much or um, maybe less predictably helpful. Similar thing with Botox. So Botox, like I said, is a medication that weakens whatever muscle you inject it into. If you could advance the slide, James. So this is what Botox looks like, right? And so both for dilations and for Botox, the upsides of both of these procedures is they can be done both with anesthesia, where there's sedation and there's support from anesthesiologists for comfort and for safety, but they can also be done safely awake. And there are a few different techniques for those. So those are two upsides of these two procedures. And what Botox looks like on that left picture, you can see kind of a similar view where we're looking at the cricopharyngeus muscle. And so to orient you, what we're looking at here, this is looking through a patient's mouth, down through the throat, into the opening of the esophagus. And so that ridge up there, which is shown by the arrow, the white arrow, and Dr. Clark's marker is kind of the frontmost border of the muscle, the CP muscle. Okay. And so because we're looking down, the top of the picture is the front of the patient, the back of the picture is the back of the patient, and left and right are respective. And so once we expose that muscle, we inject the Botox directly into the muscle again, in theory, to weaken the muscle. This picture on the right shows one of the techniques that can be used to inject the muscle in an awake setting. There are other techniques as well. But again, the idea for Botox is you weaken the muscle, which is usually tight at rest. And as you weaken that, then in theory, it should be able to open better. Botox for swallowing disorders for inclusion body myositis is a little controversial. Part of the reason for that is, I believe that, the fundamental problem for inclusion body myositis is that it's an inflammatory myopathy. And so what that means is that the way the disease causes problems is with inflammation of the muscle. And so if you have constant inflammation of that cricopharyngeus muscle over time, eventually that muscle will become scarred. And as muscles get scarred, they stop functioning properly, and their response to medications may also change. And so, if you have a really scarred cricopharyngeus muscle, then the Botox may not be as effective. And there's also data that show that a percentage of patients who get Botox can get potentially worse. Another downside to dilation and Botox is that the effects of both of those procedures can sometimes be short lasting. They can be temporary and may need additional procedures down the road. And so lastly is the myotomy. That's kind of the third mainstay of treatment that we have. This is a swallow study that was published by Bonnie Martin Harris on a website called Dysphagia Cafe. And so what you're looking at, the black colors are the barium, which is a liquid that shows up on an X-ray. And so you're looking at a patient from the side like this, okay? And so the X-ray is shooting this direction. And you can see the swallowing tract as the barium is passing through the phases of the swallow. And so that the indention at the bottom right part of the picture right there, that's the cricopharyngeus muscle. That's the gatekeeper to the esophagus. Okay, and so that's the muscle that we're targeting with these treatments. And above that, that contrast that's in the throat, those are the muscles that should be working as a pump to push food down. Okay, and so in inclusion body myositis, again, pump is weak, so not squeezing as well, and that valve, the CP muscle, is not opening as well. And so the idea for myotomy is to essentially cut the muscle. There are two approaches for doing that. One is from the inside, working through the mouth, and one is through the neck with a surgical incision, usually on the left side, sometimes on the right, to go in, approach the esophagus from externally, and cut the cricopharyngeus muscle that way. There are pros and cons to both of those approaches that probably are outside the scope of this webinar. And so this is the instrument. So if if you and your physician decide that you want to move forward with a myotomy and you decide that you want to do it endoscopically, meaning working through the mouth, this is one of the scopes that we can use to expose the muscle from the inside. Essentially, this is a muscle that goes through your mouth to expose the muscle and allows us to work through it. And once we get that muscle exposed, what it looks like, you can see on the left, this is looking through the lumen, through the opening of that scope to expose the muscle. And again, you can see looking downward into the screen that the bar of the muscle there that's kind of obscuring the entryway into the esophagus, which is past that muscle. Okay. And so the left is what it looks like before we cut it. The right is what it looks like after. And essentially, most people will use a laser to either divide or remove a segment of that muscle toward the middle of that muscle to um, essentially open it up. And so if you decide that, so for dilations and for Botox, those are typically done outpatient, meaning you go home the same day. And so relatively low risk, okay, especially the dilation procedure. There are very few procedural risks related to that procedure. The risks are very relatively low compared to the two others. And I think one of the downsides of a myotomy is that there are a higher rate of surgical risks. Okay. And so you saw the metal scope that we use to perform the surgery. That scope puts a lot of pressure on your upper teeth and your tongue. Dental injury is a small risk. Chips, cracks, loose teeth, even though we use dental guards to try to protect the teeth. The pressure that it puts on your tongue, sometimes some people can get temporary numbness to their tongue or changes to their taste. But even more so than that, as you can imagine, your swallowing tract is a closed system. And so if we go to that system and open a part of that system up, the main risk that we worry about with this surgery is the risk of a leak, where essentially you no longer have a closed system. And so thankfully, the risks of leaks are low. And there are different things that we try to recommend for patients after surgery to reduce the risk of leaks. Okay, things like maybe delaying what you eat or when you eat. So maybe delaying, when you start your diet after a myotomy. And a lot of people will keep patients in the hospital after a myotomy. And so those are also variable from provider to provider. Like I said, the risk of a leak, if you look at the literature, is usually cited at less than 10%. So thankfully not very common. But if you don't develop a leak, most people will leave the hospital within a few days. And if you do, a lot of times it can look like a longer hospital stay, because if you have a leak in the system, then you want to avoid passing liquids and foods through it. And so, that means giving you nutrition through other means while you're healing from the leak. Next slide, please.
Sorry, Dr.
Please.
Just
Yep.
to follow up on that, great points. Maybe you could also talk a little bit about people who have failed Botox and balloon dilation, because there's definitely patients who come in with IBM who have failed those treatments. Would you still perform a myotomy on them?
I usually would. What I counsel my patients, I think that there's not good data for this. So this is primarily my opinion. And so My approach for inclusion body myositis patients, I typically recommend myotomies up front as long as patients are having obstructive type symptoms, meaning those types of symptoms with foods that we mentioned before, having to take smaller bites, having to chase with liquids, maybe modifying your diet. And so I usually am relatively forward with recommending myotomies up front. And that's for a few reasons. One is I think that with dilations in particular, the degree of improvement that you get may not be as good as you can get with a myotomy, and the duration of improvement that you get may not be as good as what you can get with the myotomy. And the reason for that is if you're just stretching the muscle, there's still muscle fibers intact. And so you may not stretch it open. You probably won't stretch it open all the way to the natural opening capacity of the esophagus. Whereas with a myotomy, if you divide all of those muscle fibers, then in theory, you should be able to get the opening bigger and potentially um, um, a longer duration of effect. There are some people who need revisions after myotomy. Sometimes that cricopharyngeus muscle can reform. We're not entirely sure why that is. It's probably either because there are a lot of fibers to that muscle, and it's actually surprisingly not. You can miss some of those fibers during surgery, and if you do, we think that maybe sometimes those fibers over time can grow or become more prominent, and that can kind of result in a recurrent muscle, so to speak. Or maybe sometimes with the edges of those muscles, once they're cut, maybe those edges can scar back together and reform that muscle. Um, and so for patients who have dilations and are still having symptoms, in theory, maybe the myotomy can provide additional benefit, even if the dilation didn't help. I kind of have a similar thought with Botox, where let's say the Botox didn't help. Maybe the muscle was too fibrotic for the Botox to have an effect. I tend to actually stay away from Botox myself. I tend to recommend against it because there are a certain percentage of patients who I believe get worse after getting Botox. And so even in the setting where if Botox doesn't help, I usually recommend myotomy as well.
I would agree. I think with the Botox, even though it weakens the muscle, you still have that mass of muscle just sitting there that is still making it hard for the bolus to travel from the throat down into the esophagus.
Agreed. And it's really hard to keep that Botox all into the cricopharyngeus muscles. Sometimes some of the Botox can diffuse into those pump muscles, right? So meaning it can spread to some of those pump muscles, and those pump muscles, which are already weak, if they get additionally weakened, then I think that's where sometimes some people can get worse as well. Um, this is the biggest study looking at procedures for patients with inclusion body myositis who have some sort of procedure, and these are all patients who have cricopharyngeus myotomy procedures. This was published out of the Mayo Clinic, and essentially this was 40 years of data with 40 patients. Okay, so still not that big. They only had 40 patients with myotomies in 40 years. And the way to read this table at the bottom, essentially, these are all patient-reported outcome measures. So what that means is surveys that patients fill out on their symptoms. And you can see the pre and the post for all of these outcomes is higher before having the myotomy and lower after having the myotomy. Usually what this means for all three of these scores is that a higher score means that you're having more symptoms, and a lower score means that you're having fewer symptoms. Okay. And so not a perfect measure, but in general, the takeaway message is that people who have myotomies in the setting of inclusion body myositis can get improvement to their symptoms. And then kind of lastly, this is something that we get questions about all the time, right? And sometimes some patients come in who already have a G tube. And so a G tube, what that is a feeding tube into the stomach through the skin of the belly that allows for delivery of nutrition directly into the stomach, bypassing the swallowing mechanism, right? And so there are kind of two main roles for this. One, for patients who have a really unsafe swallow and are essentially not able to maintain their nutritional needs or getting recurrent aspiration pneumonias. this provides a way for patients to get nutrition without having to swallow to swallow food to get nutrition, or to bypass swallowing if patients are at high risk for aspiration pneumonias. Okay, so this is kind of used in two different ways. One, sometimes patients with really unsafe swallows um, sometimes can depend entirely on G-tube access for the nutrition, or for some patients who have impaired swallow, but not necessarily entirely unsafe. It's just one of the things that can happen for patients with dysphagia is it takes longer to eat, right? A lot of patients will tell me they're the last person at the table, takes them a long time to eat. And over time, if that gets worse, if that amount of time goes up and up and up, eventually you can get to a point where even if you were just eating all the time, you physically cannot meet the nutritional demand of your body to get the nutrition that you need. And so you can supplement with nutrition through the G tube while still participating in meals, eating for pleasure, etc. Um, this is something that uh, we got a lot of questions about as well. So IVIG is a non-surgical option that is provided by either neurologists or rheumatologists that can have a role in inclusion body myositis. It's understudied. So, the studies that have been done are limited and are not necessarily conclusive, but there's some evidence that maybe IVIG can help temporarily with swallowing symptoms. At the same time, there are some studies that show that there's maybe not a meaningful sustained improvement to swallow strength. And so again, kind of like the other data that are out there, it's not entirely consistent and sometimes contradictory. Did you have any other additions to that, James?
No, that's essentially my take on it too. It's obviously not something I prescribe in my practice. I think for a certain small group of patients, it may be helpful. Um, but usually, if they come to my practice, they have other issues that need to be addressed.
Yeah, I would echo that. It's the same for me. Laryngologists, surgeons are usually not the ones who are making recommendations or treating with GIV specifically, right? So these IVIG is typically managed by either neurologists or rheumatologists. And so if any of y'all have any questions specific to these things, I would ask those subspecialists. Um, this is a disease, and truthfully, all swallowing diseases are um, problems that impact not just patients who have them, but also their caregivers and their families. Eating is such an important part of being human, and is such a culturally important thing that it really impacts people's quality of life and their connection to their loved ones. And so. Uh, I always encourage our patients to have their caregivers and family come with them to their appointments and even to their therapy sessions. A lot of times, there's a lot of information that we give at one time, and it's very easy to just not retain everything that's discussed. And so having a second set of ears there, having additional input, right? Additional input from family members in terms of even individual patient symptoms, right? Because sometimes we can all downplay what we're feeling, but maybe our family members have a different perspective. And so having, your loved ones there for support, I think is really important. And, if you are a caregiver or a family member for somebody with inclusion body myositis, I would strongly encourage you to participate in their care, come with them to their appointments, and even learning things from therapy, working with speech language pathologists, or um, you can be an advocate for your family member who has inclusion body myositis and help with some of the exercises and techniques that are learned during therapy. And that kind of wraps up the formal portion of this. Just wanted to again thank everyone for attending, and thank you for hosting this. It's really been an honor for both of us.
Well,
Yeah, thank you.
I'm sitting here saying to both of you, Dr. Yang and Dr. Clark, We're giving you an incredible round of applause. It was a fantastic presentation. One of the things that you said is have your caregivers, have your other people. This is being recorded. This will be on the TMA website the beginning of June. We're going to go into a couple of other things in a minute. So as I got you both on here, and through Dr. Clark and Hopkins, as we learn more about the study that they're putting together with IBM and swallowing, we will definitely keep you posted. We will send out whatever information as soon as it's available. And I'm sure it will also be available, it'll be in various places. So with that, with both of you, we wanted to kind of tie this together um, with a couple of stories from some of our women just so that you hear a little bit more about what we go through. So I'm going to turn and ask Sharon McCall to just switch our slides. And I'm giving you guys, let's give them, as they're still here, another round of applause for them. Um, so if you can stay on, and if the two of you want to comment, we have three women that have been here and with various places of IBM. Um, I'm going to start first with Sharon C., who's around. I know she's here. So Sharon's gonna just so that we know, we along with our teams need to be able to we communicate with everyone else in what's going on. So let's start with Sharon, then we'll hear from Janet and Donna for a couple of minutes. And if either of you Dr. Clark or Dr. Yang want to comment, please do. Sharon, where are you? Are you still here? Did you unmute yourself?
I'm here.
Okay, so you're first, and thank you because I know it's been a busy week for you.
I had a daughter get married and a daughter fly in from New Zealand, so it has been busy. All good things. So hi,
Thank you.
everybody. I'm Sharon. I live in Chicago, and I had a cricopharyngeal dilation. I think that's what it is, on September 9th of last year. I have had IBM probably for 14 years, officially diagnosed in 2022. My very first symptom was dysphagia, and that was in 2012. So anyway, I recognized it because my father also had IBM. And I had an episode a couple years ago that was really scary. I needed to have the Heimlich. And so I decided to pursue this dilation. And I was told that I needed to have another one probably within a month or so after the first, just because the evidence was that my results would be better. I was not able to do that because we moved so I could be all on one floor. So I still am better than I was, but it's starting to get worse. So Dr. Yang, it was interesting that you go right for the myotomy. So anyway, now that this wedding is behind me, I'm rededicated to working out and figuring out this dysphagia. So anyway, that has been my experience. Um, I I'm very careful. I will do my swallow studies once a year. My swallow studies coming up next week, and hopefully I'll have some more information about how I'm doing. Um, And I have done physical or therapy, swallow therapy, and I'm going down on Thursday to Shirley Ryan Ability, which is the old Chicago Rehabilitation Institute. And hopefully I will learn more there about things I can do. But you can hear that I'm starting to get hoarse.
Thank you. Thank you. Thank you very much. Um, it's difficult as we go on our journey talking. Let me have Janet, who is unmuted, talk a little bit about her journey. Thank you.
Hi, everybody. I remember walking into a party in 2005 and picking up a cube of cheese, which I love, and suddenly I couldn't speak to anyone. I couldn't swallow it. I couldn't greet people. I couldn't say thank you to the host. I couldn't get quick enough to the water. And I'd never heard of such a thing. And I had no idea what it was, and probably thought that, I guess I ought to behave better. I ought to not just grab for things. I ought to eat more slowly, whatever it was. Anyway, I think I handled that with lots of water and being careful, and didn't connect it to anything else until my first neurology visit for my IBM diagnosis. And the neurologist, did all the little muscle things and then said, "Now, is there anything else?" I said, "Like what?" "Well, some people have trouble with swallowing." And I said, "Oh, well, yes, absolutely." And to the report from Dr. Clark that the incidence of swallowing problems in IBM is between 40% and 80%. If that neurologist hadn't asked me, I never would have reported that as a connected thing. It never crossed my mind. How would swallowing be related to quad problems? So I was sent immediately to see their academic speech language pathologist to have the modified barium swallow and to understand where in that complex swallowing process this might be coming from. And the result was the pathologist said, "Go to speech therapy, start the exercises. And by the way, based on what we have seen on your study, your problem is not in the place where the myotomy would be of any value. Do not let people press you in that direction just because they hear you have a swallowing problem." So that was interesting to me. So I saw a speech pathologist. I got the exercises, the hold your Adam's apple up, the stick your tongue out. And I got very dedicated to them 3 times a day, every day, in a routine. And I feel like things really did get better. That after a year or so, I could say, "Oh, I'm not grabbing for water every single time I take a bite of something." But you got to keep this stuff up. And it's the same problem as with our physical therapy and our exercises. It's just really hard to keep doing that every day for the rest of your life. So I kind of had some backsliding on the exercises and on the results, and I don't know if the results would have held if I'd been more assertive about my exercises. And in recent years, I've seen, starting last year, a new speech pathologist who got me recommitted to at least some of my exercises. And so I feel like I'm on a good path again. And my take homes from the whole thing are: have a study, the swallow study, so you know what's affecting you. Find a way to get the exercises or the whatever therapy to be something you can keep up. And that's extraordinarily difficult to do that for the rest of your life. And let's get some more studies on this stuff. All these things are, 12 people for 12 weeks or something. And that's not where we are. We need real studies that will tell us in bigger numbers what's going on. So my repeat swallow study last year told me that these were approximately where they had been 9 or 10 years ago. And so actually, I felt like that was a good result, since this stuff can be so degenerative over time. And certainly my walking or my grip strength is not the same as it was 9 or 10 years ago. So I'm satisfied that I've been able to keep my swallowing there. That might be enough.
Janet, thank you. Thank you for talking about your journey. And I'm sure that we're going to be, you know, we'll be in touch soon. Um, and Donna, I know Donna is on the phone also. Donna, are you here? I know you're here. I saw you. I don't
There we go. I
see.
think I'm good now.
Okay, great. Thank
There.
you. Thank you. Thank you.
Hi, I'm Donna from Newark, Delaware. I was diagnosed with IBM in May of 2020. I initially had some swallowing issues where I could tell something was going on. I did have other symptoms that started me on the IBM to get diagnosed with IBM. Early on, it wasn't swallowing, and then as the years progressed, I could tell the swallowing was getting was coming. The swallowing problems were occurring. So I did have in 2022 and 2024, I did have swallow studies, and at those times, I did go to speech therapy, excellent speech therapy program at University of Delaware, and I did a lot of exercises, and then just like Janet had mentioned, there's just so many exercises, so I kind of fell off the bandwagon with the exercises in 2022, and then 2024 I went for another swallow study and got back on the bandwagon and did, faithfully did the exercises, and then the swallowing was getting worse recently, and I was getting totally frustrated. We like to go out socially to eat with friends, and that was a problem. I was taking home a takeout box everywhere we went, and then ended up throwing out the food and really getting frustrated. Everything was getting stuck. I was drinking so much water. I was so full all the time just from all the liquid. So after the conference, I had thought about the dilation, but I was a little concerned because a lot of doctors don't know about IBM. And I wanted to go to a doctor that was aware of IBM. I didn't want to just to go to any GI that could just stretch my esophagus. So after the conference, Nancy had told me that she found a doctor at Hopkins, Dr. Clark, and I called up right away, got in there with Dr. Clark to get a consult. Very impressed by him, very comfortable. He explained everything to me. So on February 12th, I did go in for the dilation. He did explain to me it's not going to make it perfect because I had the whole package going on. I have the weak tongue, I have the weak throat muscles, and I also have osteophytes in my neck, so I have these bones protruding inward, right where the sphincter is. So that was another issue. So I thought, well, it seemed like it was low risk, so I tried it. And I had it done February 12th. It has helped. It's not perfect, but it's definitely better than it was. So I thought, coupled with that, I did start back up at speech therapy over at University of Delaware. I have an excellent speech pathologist there, Kristen. So I thought if I faithfully kept up with the exercises, with the dilation, that maybe it would prolong me having to get it repeated. So I'm back to enjoying food again, and maintaining my weight, and it's worked out well so far. And I've just figured with all the downsides of IBM, I'll take this little win right now and we'll go from there. So that's a little bit of my story.
Thank you. Thank you both. Thank all three of you very, very much. We're honored. So, Dr. Clark and Dr. Yang, after listening to these two, and then we listened to your incredible presentation, um, which I think gave a lot of us a tremendous amount of insight or more insight about IBM and swallowing and dysphagia, but procedures, but also gave us the not unfortunately the knowledge that there were not many studies. And we want to be able to help in any way we can with our disease as we move forward. So we're excited about that. We're excited that both of you have incredible experience in IBM with dysphagia. Do either of you have another closing remark or any comments that you may have seen in the chat, questions you think need to be addressed?
Again, I'd just like to thank you for the opportunity, and it's just so amazing to hear these stories, and actually be able to provide some help.
Thank you. Thank you. And Dr. Yang?
I agree completely with Dr. Clark. I just wanted to applaud you guys. I think that this is really awesome. It's really great for disseminating information for patients, and especially for uncommon diseases. I think having support groups and networks like this are invaluable. So thank you for having us.
And I can't say, but to both of you, thank you, thank you, thank you. And again, we need to give everybody, or both of you, a round of applause for taking time out of your schedule to a group of people with our rare disease and to be interested in it, to know that you guys are both out there helping us. So we look forward to staying in touch and being in touch as part of our IBM journey. So with that, Sharon, what do we have next? I think and this keeps freezing. So Sharon McCall, do we have another frozen?
I'm trying to get it to advance.
That's okay. That's okay. I know one of the things that we're going to talk about that I haven't talked about is for any of you, this is May. This is Myositis Awareness Month. We need to do all we can as individuals, as groups, to create awareness for myositis, whether it's with our congressmen, whether it's with our local um, churches, whether it's our local government, our groups of friends, and anything that we are involved in. So um, TMA has a website. They're going to have several other things that are going on. I know that hopefully the women's group will have a few more, meet a few more things through the year that we will be talking about to to create awareness. We need to keep you posted on the research now that we have two physicians who are interested in our cause. Um, our next meeting for the women, we're just going to go back to basics and we're going to do some networking. We need to talk to each other as we live each day in our myositis journeys, we each talk about each other, talk to each other to help us getting through. So that will be on June 16th. Whoops, I forgot my calendar it's the third Tuesday in June, June 16th, from noon to 1:30, where we'll be networking. We'll let you know what the topic is soon. So, um, I can't say enough. I'm going to say thank you. We will follow up with everything in the chat. This incredible presentation will be posted on the Myositis Association website in the beginning of June. And please let anyone else in your myositis community know about this presentation. It's there, it will be there and available for everyone else. So with that, I'm going to say,
Nancy, one
yes,
thing you
ma'am.
had wanted to talk about the Myositis Awareness Month. Was there
Yes,
anything else you wanted to add? Okay.
no, I just did. This is
Okay.
my size. So check the TMA website. There are going to be some more events that will be going on um, through the Myositis Association. So please check that. Um, and we need to also, we talked about caregivers. For those of us who are interested legislatively, you need to know there are a couple of bills in Congress right now for caregivers. When we know more, we will keep you posted. But those are, the bills have been introduced, but they're still sitting in their committees. So anything that you know, go talk to your local Congress people, go talk to your state legislators, keep them posted. We need to keep funding going for these things. We need to know more about caregivers and get credits for them. So with that, as I said, next month we're going to just go back to basics with the women with IBM, and Sharon McCall and Laura Richardson will be here. So thank you, Rhonda Rogers, for putting up with me for the past year since we said, let's do a speech symposium and get it going. And for Dr. Yang, Dr. Clark, and in April for Teresa Walker and Janine McEwen. So with that, I'm going to say thank you, and any questions, feel free if to contact Women with IBM at myositis.org. Have a great day, everybody.